Hi, good evening everyone. Professor Gamal Saadi, Professor Hassan Khalid, Professor Ahmed Bindari. Good to see you. How are you?
Good evening, Dr. Mahdi,
Thank you
and
very much for
congratulations
the
for the
invitation.
great success.
Thank you very much for the invitation to Magdi. It's a great opportunity to be learning from my dear colleagues.
Thank you very much, Professor Gamal, for joining us today.
Moreover, congratulations, Dr. Mahdi, for the great success.
Thank you very much, dear Ahmed. Thank you very much. This is a panel discussion session, a new format for sessions. Try to go outside the normal presentations, lectures, is to raise a question and to be answered in 5 minutes in 3 to 5 slides and to discuss it between the presenter and the panelists to see what's the different opinions, especially in topics which are challenging or hot topics in which we have a debate, have a new trials to asking for answering some questions. So today we have five distinguished speakers. We have Professor Gamal Saadi, Professor Ahmed Bindari, Professor Hisham Sarah, myself, Professor Ghada Yusuf. And joining me in the discussion, Professor Hassan Khalid. Professor Hassan.
دكتور مجدي اهلا دكتور مجدي
Professor Hassan
معاك
Khalid
يا دكتور مجدي
is a past chairman of the critical care department, Cairo University, one of the experts in the field of electric physiology in Egypt. Welcome, Professor Hassan.
ويلكم.
So, without further delay, because we have another session, so we have to start. And looking for the program, I see that the first speaker is not available now. So we have to start by the next speaker, which is my dear friend, Professor Ahmed Bindari, one of the new stars in cardiology in Egypt.
Thank you,
And
sir. Actually, the presentation is recorded, and I ask Iris company to play the recording now. Please, we can play the presentation now.
Dr. Ahmed is answering a question
Hi
about
everyone.
cost-effectiveness of new drugs in heart failure. Okay.
First, I'd like to thank Professor Magdi Abdelhamid and Professor Khalid Chakri for inviting me. It's always a pleasure to be with you all. Within the next 5 minutes, we will answer a very important question. Are new heart failure drugs cost effective? First, we should be oriented that cost effect is not about putting money on human lives, but deciding where this money goes. Within the next 1 minute, I will explain the basic 3 or 4 concepts of cost effectiveness studies which most of us do not know or even do not remember. First, the concept of incremental cost effectiveness. In this example, how every 1 inch costs. How much does it cost in increasing the size of this TV? Okay? But we should be oriented by what's called the dominant strategy, which is the best option. In this example, the largest TV with the least price. In medicine, we rarely have a dominant strategy. Another important concept is the willingness to pay. The patient, of course, is willing to pay all of his or her money. The insurer is not willing to pay more. And the most important perspective in the willingness to pay is the society. How much the society is willing to pay to decrease the consequence of any disease. This is a very important concept. Another important and last concept is quality adjusted life year or QALY. For example, if we say 3 QALY, this is equivalent to 3 years of perfect health. Or 6 years of 50% health. Recognize that not all years of your life are made the same. Let's answer the first question. Are ARNIs cost effective? Is angiotensin neprilysin inhibitors cost effective? Please look with me to this paper that was published in the BMJ journal The Heart. The first author was Professor John McMurray. This is called the cost effectiveness acceptability curve. The y-axis represents the probability of cost effectiveness. The x-axis represents the willingness to pay. As we see in this figure, for increasing the willingness to pay, there is an incremental increase the probability of cost effectiveness. And this is called the willingness to pay threshold, beyond which the community is not willing to pay more. At this threshold, or just immediately below it, the probability of cost effectiveness is approaching 90%, and this is very good. Authors in this paper concluded that sacubitril valsartan represents a cost-effective option in treatment of HFrEF in UK from the perspective of the healthcare system, and this is very important. The second blockbuster in heart failure or HFrEF, the SGLT2 inhibitors, they are expensive, but are they cost-effective? Look with me to this very important paper that was published recently, just a few months ago, August 2020, in the International Journal of Cardiology. It was titled The Cost-Utility Analysis of Add-on Dapagliflozin in Treatment of HFrEF. We know that dapagliflozin is now FDA approved, and we are waiting its big brother, the empagliflozin, to be FDA approved after publication of the EMPEROR-Reduced trial. And this figure speaks about it all. The willingness to pay threshold for the community here is about 5,100 USD per each quali. And imagine what? Sit down for this. The incremental cost for each quali is much lower than the willingness to pay threshold, and this is very good. It's about 1,900 USD per quali. So the community is willing to pay a much more amount of money than the incremental cost for each quali, and this is great. My take-home message for this very short presentation that the two novel heart failure drugs, ARNIs and SGLT2 inhibitors, seem to be cost-effective in developed countries. However, it remains questionable if they are still cost-effective in middle and low-income countries. This was Ahmed bin Dari signing off, and goodbye.
Thank you very much, Dr. Ahmed, for this highly informative and excellent presentation.
Thank you, sir.
You know that in heart failure, the major problem, not apart from the mortality, is the recurrent hospitalization. And hospitalizations equal more money, cost burden for the healthcare costs. So I think any drug which decrease hospitalization would be translated into a cost effectiveness strategy.
Yes.
So do you agree? Yeah. So can be applied for both sacubitril valsartan or SGL2 inhibitors. But you know that the polypharmacy or in patients with heart failure now, the cost will be getting more and more. So in countries like Egypt, low-income countries, we have to consider the cost effectiveness for each drug, especially in highly expensive drugs like sacubitril valsartan, for example. So can you highlight this policy in drug prescription for patients with heart failure?
Thank you for these insights, Professor Magdi. To be frank, unfortunately, in Egypt, we do not have a strong database in order to calculate the quality, the incremental cost effectiveness, and for treating HFrEF. However, if we look at from the perspective of future reduction in hospitalization for heart failure, it seems that the pharmaceutical industry that could put some patient support programs for the Egyptian populations could cut the cost of some medications down to 25 or 50% in some cases. And I strongly advise our cardiologist colleague, do not wait or hesitate to start the four blockbusters or the quadruple therapy, as it's now said, for treating HFrEF, the beta blockers, the RAS blockers, the MRAs, and the SGLT2 inhibitors. This is because we have recent publication that combining those four drugs could add about 6 to 8 lives in the long-term survival of patients with HFrEF, and at the same time, when putting into consideration that these drugs cut the risk of heart failure hospitalization, we can imagine that they may be cost-effective in some economically burdened countries like Egypt. However, I'd like to finish my comment that we do not have, unfortunately, a well-formed database in order to derive a cost-effective analysis for these molecules in Egypt.
Great answer. Thank you very much, Dr. Ahmed.
Thank you, sir.
So, yeah. So for the sake of time, we have to move for the next speaker. I think next speaker, myself, is going to present sorry. So, share screen. So my presentation is regarding a very important question for heart failure during the era of COVID-19. COVID-19 and heart failure risk and tips in. This slide summarizes the pathobiology of COVID-19. All of us know this background for the pathobiology, how the virus tackle this system, including the pathway until the bad effects of angiotensin 2, which lead to acute lung injury, adverse myocardial remodeling, etc., etc. And this slide summarizes the hypothesis of cardiac injury in COVID-19. Is it due to ACE2 mediated direct damage? Could be. Or hypoxia-induced myocardial injury, which lead to increased oxidative stress, intracellular acidosis? Maybe. Cardiac microvascular damage and vessel hyperpermeability, angiospasm, or systemic inflammatory response, high level of cytokine storm, and excess inflammatory reaction. This will lead to, at the end, acute cardiac injury. And this slide summarizes the different presentations of COVID-19 cardiac manifestations: acute myocardial injury, myocarditis, type 2, cardiomyopathy, infarction type 2 or type 1, pericarditis, and look for heart failure, maybe de novo heart failure, acute decompensated heart failure, HFrEF or HFpEF, different arrhythmias and sudden death. And this slide showed the importance of myocarditis in patients who develop COVID-19, and this was proved in biopsy and high levels of biomarkers and high risk for mortality. And this slide summarizes in patients develop symptoms is it COVID-19 or is it heart failure? This is a Canadian Cardiovascular Society recommendation. And you have to differentiate by looking for increased individual risk of concomitant COVID-19, presence of fever and or de novo viral symptoms like cough, myalgia, and fatigue, and absence of typical features of heart failure. Acute decompensated heart failure is characterized by increased body weight. The symptoms of paroxysmal nocturnal dyspnea is different from shortness of breath due to COVID-19. Lack of response to appropriate heart failure therapy, especially diuretics, which is characteristic for heart failure. Natriuretic peptides cannot differentiate because COVID-19 could be associated with a high level of natriuretic peptides. Follow-up is very important, and this is algorithm shows that the history suggestive of COVID-19 and de novo viral symptoms and fever, this suggests COVID-19. But patients who have symptoms and signs, weight gain, edema, heart failure, paroxysmal nocturnal dyspnea, this is heart failure. And in between patients who have cough fatigue dyspnea could be COVID-19 or heart failure, and this is very important. This is a very important recommendations by the Heart Failure Association of the European Society of Cardiology for general prevention measures for patients with heart failure is to avoid close contact with other persons, to keep at least 2 meters distance, to stay at home, wash your hands frequently, don't stay in the same room, all protective measures for prevention of COVID-19. Practical tips: try to keep active and exercise at home, try to secure enough your heart failure medications, stay on your current medications treatment and the doses, continue treatment with ACE inhibitor, ARBs, and beta blockers, and don't self-medicate. Try to avoid stopping drugs and avoid the non-steroidal anti-inflammatory drugs. Seek medical attention if you experience any symptoms like chest pain, increased shortness of breath, or dizziness, and avoid routine clinical hospital visits except in emergency. And you have to be quarantined is recommended if you have any symptoms suggestive of COVID-19. And the patients with heart failure are often shortness of breath on exertion, and this can also get common cold. The same symptoms may be like COVID-19, so clinical evaluation is very important to differentiate between both. Fluids are important and paracetamol effective for patients. Avoid non-steroidal anti-inflammatory again, and you should use a mask to prevent spreading of virus. All preventive measures should be taken in consideration. So these are just the practical tips for patients who have heart failure and can develop acute decompensated heart failure due to COVID-19, or patients with heart failure, how to avoid to develop COVID-19, what are the recommendations regarding the use of his medications during COVID-19, don't stop medications, and this is very important to avoid acute decompensated heart failure. Thank you very much. If there's no questions, we can move to Professor Gamal Saad. If anybody
one small comment.
Yeah.
Usually any heart failure who develop fever and bad chest, especially positive CT chest, should be suspected of COVID and have PCR. But if a patient develop de novo heart failure after developing fever and cough, this is maybe myocardial injury due to COVID-19. Thank you.
Yes, exactly. Exactly, Professor Hassan. I'd like to welcome Professor Mervet Abu Maati. She is the president of the working group of electrophysiology, one of the very active working group in the Egyptian Society of Cardiology. Welcome, Professor Mervet.
Welcome, everybody. It's my honor to be with you on this stage in this virtual meeting. Or hybrid.
Yes, hybrid. Thank you very much for joining us. We are waiting the next session, which is expected to be hot topics in the electrophysiology session after this panel discussion.
Okay.
So I have the pleasure to invite my dear friend, Professor Gamal Saadi, Professor of nephrology at Cairo University, one of the experts in the field of nephrology. And I'm always happy to join Professor Gamal because we know that crosstalk between cardiologists and endocrinologists and nephrologists, and Professor Gamal is joining us in many sessions. And it's a great honor to join us today, Professor Gamal.
Thank you very much for the invitation and for the opportunity to be joining this very elegant meeting and elegant group. I will take from your last sentence that the field of cardiology and nephrology, many of the cases have problems encountering both these issues. And this first slide shows the importance of the benefit of using SGLT2 inhibitors in patients with established cardiovascular disease and chronic kidney disease together, where you can notice that empagliflozin has an important effect on reducing the time to cardiovascular death. So this is a very important issue. I will refer only to one important article which was published in this month, October 2020, and it addressed 6 major trials, and it comprised about 47,000 patients, and it encountered that the largest benefit across the class was for an associated reduction in the risk of hospitalization for heart failure and kidney outcomes. It did not find a significant effect on the cardiovascular mortality itself. In this study, the 5 major trials were considered: the EMPA-REG, CANVAS, the CLARE, and the Credence study. And in that study, there was a significant benefit of using the SGLT2 inhibitors in the outcome of kidney disease and chronic kidney insult. The significance was among all the class, and particularly among the empagliflozin and the dapagliflozin more than the canagliflozin data. It is important to notice that initially we encountered a drop in the estimated GFR and probably a rise in serum creatinine, but on the long term, there is a beneficial effect on the preservation of the residual kidney function and the preservation of the filtration rate. So this is an important outcome of using the SGLT2 inhibitors. And it is important to mention that in patients with chronic kidney disease, we have limited choices of hypoglycemic agents which are safe, avoiding hypoglycemic insults. So we need to avoid as much as possible insulins and sulfonyl ureas. Metformin can be used up to stage 4, but cannot be extended to stage 5 or patients on dialysis. There is a warning to use the SGLT2 inhibitors beyond or lower than GFR of 45 milliliter per minute. We can continue using them up till 30 milliliter, but if they were already started. I need to mention here that in some studies with patients with residual kidney function who extended to stage 5 or are on dialysis, there are studies to still use the SGLT2 inhibitors to maintain or preserve the residual kidney function, but these data are still under evaluation. And the importance of the initial drop in the GFR is related to a tubulo-glomerular feedback mechanism rather than a functional effect in the glomerular pressure. Actually, the SGLT2 inhibitors maintain the filtration in functioning nephrons. That is why they are important to maintain the residual kidney function, which is the most important parameter delineating the longevity of the patients with chronic kidney disease, having eventually cardiovascular risks. Using the SGLT2 inhibitors sets down the filtration threshold per nephron to a level which is lower than physiologic. And that is the factor which underlies its preservation of the residual nephron function. It's important to note as well that they have an important effect on reducing the albuminuria or proteinuria, and this is a very important parameter in preservation of the residual kidney function as well as a biomarker for the outcome of cardiovascular risks. This slide shows the importance of considering the use of these agents to start them only up to 45 milliliters per minute, but they can be used up to 30 milliliters per minute. And we should consider using them in CKD5 or patients on dialysis as still under evaluation. I'm not going to extend on the beneficial effects on the cardiovascular mortality because you are more aware of me than this, but to highlight that in this paper that they delineated a marginal effect on the improvement of the overall measure and first cardiac events. They did not have a significant effect on the cardiovascular mortality, but it was only with empagliflozin that it showed a significant effect. Also, this was found in the atherosclerotic cardiovascular disease, and this was more noticed with empagliflozin as well. As you noted, that it's most important effect in reducing the heart hospitalization for heart failure, and this is the most important comorbidity with chronic kidney disease. Thank you very much.
Thank you very much, Professor Gamal, for this highly informative presentation. My question, Professor Gamal, that you know that in patients with heart failure, around 40 to 50% of patients have renal dysfunction with the low GFR. So with the use of SGLT2 inhibitor, how to monitor the kidney function after initiating dalagliflozin or empagliflozin in patients with heart failure?
To initiate them de novo is not that easy. It is important to maintain them, as you mentioned in the COVID cases, to maintain them if they were already started. But to start them de novo in patients with low GFR, this might be a bit risky, particularly that you notice that in the initial phase, which would be considered in 3 or 4 weeks, that there might be a further reduction of the GFR and rising of the serum creatinine, and this might be a bit crucial to start them de novo. We should maintain them if they were started and to monitor the GFR. Particularly if they were used with RAS blockade, particularly the ARBs, the beneficial effects of the SGLT2 inhibitors in such situations, and as in your talk about the COVID, is that they are beneficial only when combined with RAS blockade, and they should be both maintained but not started de novo.
But if the patient developed acute decompensated heart failure or acute illness, should we stop SGLT2 inhibitor?
If they were recently started in the first months before this development, yes, they should be stopped. But if they were introduced earlier and we don't have a state of fluid loss, or we don't have a state of ketoacidosis, we can maintain them. But if we have ketoacidosis, we should stop them. If we have a state of dehydration or pre-renal factor, we should stop them. But for functional effect, without these factors, we can maintain them.
But adjustment of the dose of diuretics is very important with the use of SGLT2 inhibitors.
Sure, because it's crucial to avoid lowering of the filtration pressure, and combining diuretics with the SGLT2 inhibitors might lower the filtration, particularly in AKI conditions. So it is mandatory to be measuring the central venous pressure to consider that there is no pre-renal effect.
At what limit or cutoff level of GFR you can start SGLT2 inhibitor, Professor Ben?
In stable conditions, In stable conditions, we are safe according to the guidelines to use them if we have a GFR above 45 milliliter per minute. In more randomized controlled studies recently, they are starting them at lower GFR, and as I mentioned, they are still considered in patients with residual kidney function having still urine output in CKD5 and even in dialysis patients, but these are still under evaluation. So we can start them in stable conditions, but with acute kidney insult, it's not wise to start them.
Thank you very much, Professor Gaman, for this fruitful discussion and excellent presentation. Thank you very much.
You are welcome. Thank you very much.
Now we are going to Professor Ghada Said. Professor Ghada is going to answer a question: how to monitor your patient while receiving chemotherapy. Professor Ghada is Associate Professor of Cardiology at the Cairo University.
Hello, sir.
The most experts in dealing with heart failure with pregnancy, heart failure with chemotherapy. Ghada.
Thank you, sir. Thank you so much, sir. Thank you for kind invitation. It's always an honor and a pleasure to be among my esteemed professors and colleagues. Actually, I have recorded the lecture before. My colleagues, this lecture is to answer the question of how to monitor your patient while receiving chemotherapy. The questions to be answered are what to monitor, who to monitor, when to monitor, and how to monitor. What to monitor? We mean the possible effects of chemotherapy on the heart. Different chemotherapeutic agents cause different spectrum of cardiovascular diseases, the most important of which are heart failure, arrhythmias, ischemia, hypertension, pericarditis, and thrombophlebitis. Who to monitor? We mean the patient's risk of developing cardiotoxicity, which patients are more liable to develop cardiotoxicity. Patients with current myocardial diseases, heart failure, asymptomatic LV dysfunction, evidence of coronary artery disease, valvular heart disease, significant valvular heart disease, hypertensive heart disease, cardiomyopathy, and significant cardiac arrhythmias. In addition to patients at extremes of age, patients less than 18 and patients more than 65, patients with hypertension, diabetes, hypercholesterolemia, smokers, obese patients, and patients with prior history of anthracycline use and prior radiotherapy to such as or mediastinum. When to monitor? First, when to expect cardiotoxicity. Cardiotoxicity is expected either early during the course of chemotherapy or late years after chemotherapy. And these cardiotoxic effects are either transient, means that they are reversed whenever we stop the drug, or permanent because of fibrosis and remodeling. So the timing and frequency of patient's evaluation. First, the baseline assessment. We should assess the patient clinically and assess the risk factors, should assess the troponin BNP level, and imaging, assess the ejection fraction through echocardiography, radionuclide study, and or MRI. Then we should assess the patient through serial follow-ups. The frequency of these follow-ups depends on the type and the cumulative dose of chemotherapy, the patient baseline risk profile, and the ejection fraction. The lower the ejection fraction, the more frequent the follow-ups. And the baseline imaging modality should be the modality to be used in the follow-up visits. How to monitor the patient, how to assess the patient. We should assess the patient clinically, cardiovascular symptoms and signs, but we should not wait until the patient develops symptoms. We should assess the patient through cardiac biomarkers, troponin and BNP, and through imaging, echocardiography, radionuclide study, and MRI. Which investigation to choose? We have echocardiography 2D and 3D left ventricular ejection fraction. These are widely available and it lacks radiation. And the global longitudinal strain, which is a new modality with the disadvantage of some technical requirements. We may assess the patient using the multi-gated radionuclide angiography. It's reproducible, yet it implies cumulative radiation exposure. Cardiac magnetic resonance imaging is only used if other techniques show diagnostic uncertainty. The MRI is accurate and reproducible, and it shows diffuse myocardial fibrosis, yet the availability is limited. The use of cardiac biomarkers, the troponin, BNP, and NT-proBNP, which implies the rise of these biomarkers implies that these patients may benefit from cardioprotective drugs like ACE inhibitors and beta blockers. They are accurate, reproducible, with wide availability and high sensitivity, yet the data is still insufficient to establish significance of such changes. Thank you.
Thank you very much, Professor Ghada, for this excellent presentation.
Thank you, sir.
Ghada, my question regarding the use of GLS, and you know that our study that have been presented in the last EC meeting about the combined use of GLS and PEP for early prediction of subclinical LV dysfunction in patients receiving chemotherapy. You consider that GLS compared with standard echo, because you know the estimation of ejection fraction by routine echo is not so accurate. So GLS could be a new imaging tool for better identification of patients who develop LV dysfunction.
Yes, sir. Thank you for the question. Of course, GLS is a better option for detecting subtle LV dysfunction, and we need to know the subtle LV dysfunction before the patient develops symptoms, because if the patient develops symptoms, it's already too late to do anything. And besides, the limitations of calculating the ejection fraction, the operator dependencies, the subjectivity associated with calculation of the ejection fraction, this makes the way for global longitudinal strain even easier. And if we added a biomarker to the global longitudinal strain, this increases the specificity of these sensitivity and specificity actually of these investigations to detect subtle changes, so we could add cardioprotective drugs as early as possible to prevent the cardiotoxic effects as early as possible.
Some physicians are giving cardioprotective drugs, ACE and beta blocker, as a prophylactic before detecting a drop in the ejection fraction.
Yes, many studies. Yes, yes, sir.
It is right for this policy to give these drugs.
No, it's not. It's not a policy until now. It's not quite evidence to start with cardioprotective agents before the actual occurrence of LV dysfunction. But there were many studies who studied different classes of beta blockers, ACE inhibitors, ARTs, and even MRAs to protect the patient from the toxic effects of chemotherapeutic agents. Some showed positive results and some not. And even those who showed positive results, the results were marginal. The improvement was marginal. So they did not recommend using these agents until an actual LV dysfunction occurred, with an objective evidence, of course.
So cardio-oncology collaboration is very important to identify the baseline risk of patients who could develop this LV dysfunction, and an algorithm for management should be considered for the cardiologist in order to monitor patients who are receiving chemotherapy.
Yes, sure. We are lacking, unfortunately. Guidelines now are lacking these algorithms. They do not recommend any specific timing for follow-up of patients. They said according to the patient risk, according to the type of chemotherapeutic agent, according to the dose of chemotherapeutic agent, but they did not propose a certain algorithm. So there should be some sort of cardio-oncology team consist of an oncologist and a cardiologist, and they should agree to the regimen the patient is going to take and the frequency and the timings of follow-ups.
Thank you very much, Dr. Ghada, for
Thank you, sir.
presentation and great discussion. Thank you very much.
Thank you.
Thank you very much, Professor Gamal Saadi, Professor Ahmed bin Dari, Professor Ghada, for this great session and excellent discussion. Thank you very much.
My honor. Thank you very much.
Thank you, sir. Congratulations.
Now we will move to last session. Now we will move to the last session in the heart failure conference. I have the pleasure to co-chair this session with a distinguished group of chairpersons and speakers in the group of electrophysiology led by Professor Merbat Al-Maadi, Professor Hassan Khalid. I see Professor Hassan, Professor Merbat, Professor Lamia. I didn't. Yeah, Professor Ghalia. Yeah. Dr. Ghalia, how are you?
احمد الضماطي مش موجود.
دكتور مجدي مساء الخير.
دكتور احمد, how are you? ازيك يا احمد؟
How are you, Dr. Magdi? It's always a pleasure to be part of this.
Thank you very much for joining us today. Thank you.
It's my pleasure.
ممكن